Hello, good evening, Yogeshwari.
Good evening. Good evening, sir.
Okay, so we are actually restarting after a long time. There has been a gap because I
Yeah,
think I was busy and all of you are also busy. Doesn't matter, we'll straight away get into the topic without wasting time. Today's
sure,
topic
sir.
is a very, very important topic, that is diabetes complicating pregnancy, because the incidence is on the rise, and every
Mm,
exam time there will be enough cases of diabetes complicating pregnancy, and maybe sometimes alternate students will get this case. So without wasting much
Awesome.
time, we'll start that. Are you ready?
Yes, sir.
Right.
Sure.
Good. So as usual, before starting the case, let us discuss few things about diabetes, which is very important as a prelude.
Mm,
Okay.
yeah,
So what is diabetes? That's the main question, whether it is in obstetrics or otherwise. Everybody wants to know what is diabetes and why is it so important for us to know that.
yeah. So diabetes is a metabolic syndrome which is characterized by glucose intolerance, and that could be either due to a decreased insulin production or an increased insulin resistance.
Yeah,
And why
very
is
good.
it
This is a
important? Because
very, very important thing to understand. After all, insulin is the one which takes care of the sugars. Either there has to be a decrease in the insulin production, or there is enough production, but there is resistance. What do you think happens in pregnancy?
so
Is it
in
decreased
pregnancy,
production or increased resistance?
it is increased resistance because of the action of the placental hormones.
Or we also call it
And
sensitivity, isn't it?
yes, sir. Yes, sir. And why is it important? Because we being in India, it's like the diabetic capital, and the diabetes is a it affects the multiple organs, and especially more during pregnancy. And the complications are grave for both the mother and the fetus. So the thorough understanding is required about the disease for its adequate management.
Very aptly said, because this affects not only the mother, it also affects the baby. As we go along, we will soon discuss all those issues. And as you said, in diabetes, the organs are exposed to chronic hyperglycemia, and that will give rise to all the problems that are there in diabetes. So, as you correctly
Yes.
said, it's the most common medical complication of pregnancy. About 5 to 15% of women with GDM may develop
Mm.
type 2 diabetes within 5 to 15 years of index pregnancy. That is the worry. The
Yes.
diabetes that comes during pregnancy may go off, but 5 to
Mm.
15% of women will eventually get type 2
Yes.
diabetes in their life in a span of 5 to 15 years. From the
15 years.
index pregnancy means the pregnancy in which the GDM was diagnosed.
Done.
Very good. So far,
Okay.
good going. Let's see what is the effect of pregnancy on diabetes. I'm not asking you about diabetes on pregnancy, but pregnancy on diabetes. Is there anything that pregnancy complicates the diabetes or worsens the diabetes?
Definitely, so pregnancy itself, like we have taught, it is a diabetogenic state where there is increased maternal demand, energy requirement for the mother and for the fetus, and there is going to be an accelerated insulin resistance, or like if she's newly diagnosed, there's going to be an increased insulin resistance due to the placental hormones. So hence, pregnancy is affected a lot by the diabetes itself. And there is going, in case if she's previously diagnosed with diabetes, her whatever state that she's on gets worsened during pregnancy as well.
Correct. So there is an increased insulin requirement during pregnancy, as you said,
Yes.
because there is increased resistance or insensitivity
Mm.
to insulin during pregnancy. So if the
Yes.
person is already diabetic, the pregnancy will make sure that there is increased insulin requirement. Also,
Mm.
the most important thing to understand during pregnancy is that there is exaggerated fasting hypoglycemia, especially in the first trimester. Now, this is
Yes.
very, very important later when we try to diagnose diabetes during pregnancy. The
Mm.
parameters or the cutoffs which are followed by physicians is totally different from what is
Mm.
followed by obstetricians. And this is basically
Yes.
because of exaggerated fasting hypoglycemia. For
Fasting.
example, in medicine, they will say 125 is okay, right?
Yes.
Up to 125 fasting, they will not brand you as a case of diabetes. Whereas in
Yes.
pregnancy, as low as
92.
92. Why is that? That is
Mm.
because of this phenomena. That is, there is
Mm.
exaggerated fasting,
Fasting,
hypoglycemia, especially
hypoglycemia.
in first trimester, because there may be nausea, vomiting, she's not taking proper food, and all those things. Okay,
Mm.
this is very important. Another effect of pregnancy on diabetes. And number three, as you
Yes.
already mentioned, there is worsening of established nephropathy, retinopathy, and neuropathy. So this is very, very important to understand. Now, let me ask,
Yes.
you said pregnancy is a diabetogenic state. Yeah, it's a very grand
Yeah.
statement that you made. In fact, it is very good that postgraduates make such statements as an introduction whenever you are asked about write a note on the diabetes. So this is a very beautiful statement that you made. Pregnancy is a diabetogenic state. Why you call so?
Yes, sir. So as previously told, in pregnancy, there is increased maternal requirement for glucose, and thereby there is increased insulin production.
And
But
who
due
is
to the
culprit?
action
Who
of
is the culprit?
human placental lactogen,
Yes.
and along with estrogen and progesterone, these
In other
hormones
words,
will
steroid
further
hormones.
increase. Yes, sir. The steroid hormones will increase insulin resistance by decreasing the affinity of insulin to its own receptors. So thereby there's going to be a lot of glucose and lot of insulin, but the energy is not going to be used up by the cells, and they're shunted to the fetus and leaving the mother in a hyperinsulinemic state. And thereby this causes increased lipolysis as glucose is not being used. She's now forced to use the fat in her body. That is going to cause ketoacidosis, which is the byproduct of lipolysis. So she's again subjected to ketones are high in her blood. So this is a vicious cycle that again increases gluconeogenesis, leaving her with increased glucose, insulin, and ketones.
So this goes on and on like a circle, as you said, vicious circle.
Yes.
So there is resistance because of the basically hormones of pregnancy. That's why many people, lay people especially, they will wonder, I'm so young. Okay, why should I
Mm.
get diabetes? My grandmother got diabetes at the age of 50, and somebody else got the age of 45. So why a young pregnant lady should get? That is mainly because of the hormones that are produced by placenta, which are anti-insulin. So there is insulin resistance, which gives also rise to lipolysis, as you said. As a result, there is increased insulin to maintain glucose homeostasis. The main job of insulin is to make sure that all the energy, food, or carbohydrates are driven into the tissues and they'll be stored as fat. So in the blood,
Mm.
again, you feel that there is lack of carbohydrates and you feel hungry. And when you are hungry,
Yes.
you eat more. And when you
More.
eat, insulin is produced. And insulin will drive away again all the glucose out of the circulation. So there is increased consumption, increased glucose requirement, and this will go on. Very good. Now, before we go to the actual case, one more question to you. Shall we first
Yes,
define
sir.
what the different types of diabetes that can be seen during pregnancy? We usually call it ODM and GDM. So can you explain for the benefit of all the PGs, what is ODM, what is GDM, and in GDM, what are
Mm.
the types of GDM?
Yeah, definitely, sir. So ODM is called overt diabetes mellitus, where a patient who's been diagnosed with diabetes gets pregnant. So, or rather, we define it where a patient's diabetes was diagnosed prior to conception.
Yes, very
There
good.
is GDM, which is called gestational diabetes mellitus. In this case, the patient is diagnosed to have diabetes. The onset has been found only during pregnancy, or she's been having, but we have identified it only during pregnancy. So that
Yes.
is
So there
GDM.
are, yeah, very nicely explained. Overt means she was diabetic before pregnancy, right? But that is very
Mm.
rare considering the young age the woman becomes pregnant, 1 to 3 per
Pregnant.
thousand live births only. Whereas gestational diabetes is the one which is because of pregnancy, or there is another variety which is called first recognized, what you correctly said. The first recognized means probably she was diabetic, nobody recognized, or let's say at this particular age she was supposed to get diabetes and it coincided with pregnancy. And that can happen any time of pregnancy, whether it is first trimester, second trimester, or third trimester. But this is again very rare, 4%. But the onset with pregnancy
Yes.
means it is something like preeclampsia, which is purely due to pregnancy. And this kind of
Yes.
GDM appears usually in the second trimester onwards. As I always say,
Yes.
the general formula, all pregnancy related complications, they appear after 20 weeks and they worsen throughout the pregnancy. So similarly,
Yes.
here the onset variety, usually first
Mm.
trimester is skipped. So what is the importance of
Okay.
this?
So we need to know the difference because in a patient with over diabetes mellitus, where the sugar levels are high right from the beginning, they are more prone for congenital anomalies because we know
Very
high
good.
glucose is fetotoxic. And
Yes.
especially in the first 8 to 10 weeks where embryogenesis, organogenesis happens. So these people are more prone for congenital anomalies and might even progress to abortions due to these anomalies.
Yes. Very good.
And on the other hand, gestational diabetes mellitus patients are prone for the other complications, like they will cross the first and second trimester, but they then suffer with polyhydramnios or macrosomia and other sudden IUDs, and complications are further in the later trimester. So we
Yeah.
need to know the difference to decide when
Yeah.
to start the
But
surveillance.
again, let me caution. Even GDM
Yes.
can cause congenital anomalies. Which variety of GDM will cause congenital anomaly of the two
So the
here?
detected, newly first recognized during
First
pregnancy.
recognized, very good. First recognized variety can happen even in first trimester because she was destined to become diabetes, only
Mhm.
pregnancy uncovers it. Whereas the one which is
Yes.
due to pregnancy, as we earlier discussed, usually skips
Mm.
the first trimester. When first trimester is skipped, baby will also skip congenital anomalies, right? So that is
Yes.
the
Yes,
importance
sir.
of knowing the two varieties of GDM. And of course,
Yes.
the one which is purely due to pregnancy, in majority,
Mm.
glucose regulation returns to normal after the delivery, right?
Delivery.
So that's why the second
Yes,
variety,
sir.
the onset variety, is sometimes called true GDM. There's nothing like true
Yes.
GDM, but this can be considered as true GDM. Okay. But
Okay.
again, as we earlier said, 15% of this variety also
Mm.
can have
Can-
actual type 2
okay.
diabetes later in life. Okay.
Yes, sir.
Okay, so you have already
Okay.
told the importance, as I said, the ODM, the first trimester problems are plenty because if the sugars are not controlled, then congenital
Mm.
anomalies are more. Then second trimester, it can be IUGR or FGR. And third trimester, of
Yes.
course, there can be IUD. But as you can see, the big box is on the left side, small box is on the right side.
Yes, sir.
Whereas when it comes to
Yeah.
GDM, the small box is on the left side. That means congenital anomalies are very
Yeah.
rare. Only if it is a first recognition value
Early
of GDM,
recognized.
then you will have, otherwise you will not have it. Then the second trimester intelligence is affected, and third trimester is the big box on the right side now. Macrosomia, as you said,
Yes.
hydramnios, and IUD. Okay, so I
Yes.
think we are almost done with this. Again, we have clarified the first recognition and onset variety, so there is no need to repeat this. Let's go to the case now. You can read the case.
Okay. Yes, sir. So presenting a case of a 29-year-old homemaker who is a gravida to paravan live one, who
Any
presented
comments
to
on
us
the
at
age?
20.
Any comments on the age?
So she belongs to a low risk. So like
Yeah.
she's not elderly, not more than 30.
Usually after 35, we say medical disorders are more.
Yes.
29 is
More
not a
common.
elderly age. Okay, good.
Yes. Um, Her last mentioned period was on 12th of July 2023, and her EDD was 17th of April. So she was referred to as at 29 weeks with complaints
So
of
you are
deranged
talking
sugars
about when she
and
was referred, not today. Okay. She
yes,
was referred
no,
at
sir.
29.
Yeah,
Yeah.
yes, sir. Yes. With high liquor. So this pregnancy was a spontaneous conception. Confirmation and NT scans were normal. Aneuploidy screening showed low risk, and her routine investigations were all normal. In first and trimester, she never had complaints of excessive vomiting, recurrent UTI, or fever. Periconceptional folic acid is taken, and she had received tetanus prophylaxis and was started on iron and calcium prophylaxis also. Anomaly scan showed no gross anomalies. However, fetal echo was not done for this patient. And her
Yeah.
glucose challenge
Is it
test done.
necessary to do fetal echo for everybody?
So although we do for our
Yeah.
patients
In
here,
Manipal,
but
we may do. Manipal, we may do for
yes, sir.
everybody. But if
But
the
if
question
a
is asked, It is not necessary.
Yes,
Okay.
sir.
This is
Necessary.
only,
Yes, sir.
which are the patients you may do fetal echo?
Sir, I would go ahead with patients with previous mothers with heart disease, or mother
Yes,
had a previous baby
correct.
with a heart disease,
Because
and
4% of the
diabetes.
offsprings can have that, right?
Yes, sir.
Yeah.
Yes, sir. And patients with diabetes and
Over
SLE
diabetes, especially because, as you said,
over
anomalies,
time.
especially cardiac anomalies, are more. Okay,
Only
very good.
God.
Then,
Yes. And other medical disorders like SLE, ANA
SLE.
global.
Yes.
Positive.
And if there is any,
Saturation.
trisomies you suspect, then also
Yes, sir.
fetal echo is important because there can be cardiac anomalies in them. But as a routine, not required, but anomaly scan is a must. Okay.
Yes. Okay. So patient that time at 25 weeks GCT was done, which was
So any
elevated, which was
comment on this
186.
GCT done at 25 weeks? Because I would have definitely liked to have little more elaboration on GCT. What type of GCT was done? What is
So
GCT?
patient,
What is
so
GTT?
patient was yes, sir. Patient was referred to us from a government hospital. So they have been following the DIPSI criteria, national guidelines. It was a
Okay, we'll
glucose
talk about that
challenge
little
test.
later. Okay, we'll talk about that little
Okay.
later. Okay, just wanted
Yes.
clarification. All right, GCT, they have done a
Yes.
DIPSI GCT, which is 86.
Yes,
What
sir.
is your interpretation of 186 according to DIPSI?
So she's definitely a patient of the GDM, sir. She has
Yes, so
glucose
there is
intolerance.
definitely. Do you think it is already
Yes.
late that they diagnosed this 25 weeks? Which is the best time to do this?
24 weeks, sir, I did.
Yeah, okay. Anyway, 1 week is not a big thing. So anyway, it's up somewhere in the second term. We'll come to the ideal one little later, but this is good enough.
Okay.
Okay, this is good enough. Okay.
Okay, sir.
And they have
And
just started medical nutritional therapy. What's your comment on that? Is that okay?
sir, we could have, if the patient is compliant and she's well aware of her sick condition, we can give her medical nutritional therapy. And but we should, after 2 weeks, we would like to check her
Yes, very
sugars
good.
with
So we
fasting
don't
and
just
postprandial sugars.
advise and leave her alone. We have to repeat
Yes.
after 2 weeks the
Mm.
sugars so that we should know whether there is a case to switch over to the oral hypoglycemic agents or not. Okay. Okay. We'll leave
Yes.
it just there and we'll move on. Okay.
Okay. And the first growth scan was done at 28 weeks that showed a single live gestation with a cephalic presentation. Placenta was posterior. Her AFI was 24.6 polyhydramnios, and the estimated fetal weight was 1.3 kgs at
So what is
28
your
weeks.
comment of 1.365 at 28 weeks? Is it
So I feel
appropriate or
it
is it
is on
like,
the I feel it's on the higher side, sir. At
yes, what
28
is
weeks, we
the rough?
expect around 1 kg.
Yes, correct. You are right. At 28 weeks, we usually expect 1000 plus, maybe plus or
Yes, sir.
minus, sometimes 200. This plus or minus 200
Mm.
will go all the time, but around
Yes.
1000. But it is definitely more. 1365 at 28 weeks is definitely more if provided her dates are correct. And if I saw your history, dates were correct because the
Yes, sir.
confirmation was done very early pregnancy, anti-scan was also
Yes.
done, and there has been
Yes.
anomaly scan. So she has had got a fairly serial ultrasound. So dates are correct. AFI again, as you
Yes.
correctly said, it is slightly on the higher. It's not slightly on the other side. It is 25.
It is
You
for
can qualify it as polyhydramnios also, right? And
yes.
what about sugars?
So again, they have repeated sugars after a month, and that time the fasting was 108, and
Very
postprandial
clearly
after
high
2 hours
for
was
pregnancy.
156.
Yeah, we
Yes.
clearly mentioned in the beginning that 92 is the cutoff during pregnancy, and by that standard, this is
Yes,
very, very high.
definitely.
Okay, very high.
Yes, sir.
And postprandial also, ideally it should be
Hmm.
153. It is 156, especially after 2 hours.
Yes.
I usually put it as 2 hours,
Okay.
easy to remember as 2 hours is
Fine.
120 minutes and 120 should be the ppbs, especially when we do it. And
Yes.
it is very clearly high, isn't it? So
Yes.
patient was
Yes,
advised
sir.
admission and sugar profile, but she
Sugar
was
profile.
referred to KMC
Yes,
Manipal.
sir.
And
Yes, sir.
actually, she
Yeah.
doesn't have, even though dyslipidemia, there is no high BP recording. Okay, so
Yeah.
shall we move on? Yeah.
Yes, sir. So moving on to her past history, she's married for 4 years, non-consanguineous marriage, and her first pregnancy was in 2021. It was a spontaneous conception, and she delivered by preterm LSCS at 8 months in view of her premature pre-labor rupture of membrane and with non-progress of labor. And at 34 weeks, she has delivered a male baby of 3.7 kgs. The baby is 3 years old and healthy too now. And that pregnancy patient does not give any history of GDM diagnosed.
I want to stop you here. Anything
Yes, sir.
surprises you in this particular page?
Sir, the baby was 3.7 kg already at 8 months. So it is
And
clearly a
and
sign of,
yeah, and you are
and
saying
there is no
no
history.
history of GDM. This does not somehow
GDM.
correlate at all. See, at 8 months,
Yes, sir.
which is around,
Yes,
let's
sir.
say, 34 weeks, if you convert it as, okay,
Yes, sir.
probably, what do you think is the cause of her PPROM?
So with the current history and with the past history, it is likely to be GDM only.
Yeah, that's what. And
She might
most
have had
probably,
polyhydramnios,
yes, very good.
polyhydramnios,
That must have given
and
rise to
infection.
PPROM, infection, whatever.
Yes, sir.
And yes,
Preterm.
infection is more common during diabetes, isn't it? And
Yes,
this
sir.
is very surprising that the baby was 3.7 kg. Usually, this is
Yes.
term baby. Like, at term nowadays,
Yes, sir.
3 kg plus, right? And at 8
Yes.
months, 34 weeks, if the baby was almost 4 kg, like 3.7 kg, this is the actual,
Hmm.
not the ultrasound estimated weight. And no history of
Hmm.
GDM is definitely not acceptable, Yogi.
Yes.
Yeah.
Yes,
So,
sir. So what? Yeah.
so that's what I was surprised. Why do you
Yeah.
think I put this question? Do you think she did not have GDM with the history of PPRNA
Oh,
and the baby was 3.7 kg at that time? So something
yes,
definitely
sir.
missing. So that is the
Yes, sir.
reason why I'm happy that you brought out this case. I don't know whether you had
Hmm.
realized this when you gave the case to me, when you sent
Uh,
the case to me.
uh,
Did you realize this?
yes, sir, we did because we had to
And
rely
I'm
on the
happy that you
patient's
kept
history.
it
We
like
didn't
that
have a
only.
report.
And
Yeah.
I'm happy that you didn't manipulate or you just kept the history like that only, so that we could discuss
Hmm.
this and bring out an issue that this is how, if you do not
Hmm.
screen for diabetes, right?
Yes.
And you may straight away land up with this kind of luck. I'm happy that at least they took a action right in time. They did a section and the baby was alive. Else, this baby
Yes.
would have had problems if they had allowed for vaginal delivery. There could have been obstructed labor. There could have been sudden IUD
Hmm.
and things like that. Very, very obviously, in the past pregnancy, uh, things have been missed. But the outcome has been good, fortunately, right?
Yes,
So
sir.
this
Yes.
clearly shows that we have to start screening right from the beginning. Now, when I
Yes.
come to the present management also, which of course I'm not referring to the KMC management because she was referred
Hmm.
only at 29 weeks to you.
29
Before
weeks.
that, so what type of GCT you already answered? They did a DIPSI type of GCT, and the
Yes.
and the value was 186. What is the
Hmm.
next thing you would have done before blindly
So,
giving her medical nutritional therapy as high sounding word? What you would have done,
yes,
Yogi?
sir. So ideally, I would have requested for a sugar profiling from the patient
Yes, or at
between
least
a
I would
yes,
have done a full-fledged
GTT.
GTT, isn't it? So this,
GTT.
even though the
Yes, sir.
DIPSI says this is
Hmm.
both screening as well as diagnostic test.
Most.
Okay. When the
Yes.
sugars are high, see, even the cutoff in DIPSI is 140, right? It is
Yes.
186.
Yes, sir.
So
Hmm.
ideally, we could have done a GTT, which, because if you do sugar profile also is okay, but GTT would
Okay.
definitely would give us a very good idea about her sugar intolerance. So which includes a fasting and a 1 hour and a 2 hour. And then, of course,
Yes.
if that is also abnormal, if values are
Hmm.
abnormal, then we could have gone for a sugar
Okay.
profile to see how we should be
Yeah.
treating, right?
Yes.
So
Yes.
before
So,
that,
so,
yeah.
so sorry to interrupt. So I had a doubt. So in case if you're planning for GTT for such a patient, what will be the time interval? Because GTT says 3 days of normal diet and then fasting. So now today she comes with GCT report. When will I plan her GTT, sir?
Yeah, same thing as you correctly said. You can give a 3 days gap because during the
Okay.
GCT, you are not doing anything more other than probably 75 grams of glucose was given, and they would have taken blood
Yes, sir.
for 2 hours. So that is
Yeah.
okay. And then you allow her for maybe 3 days to have a normal diet and then
Okay.
call for a GTT. Or Even if you did the next day, very next day, it is not wrong. It all depends upon how much time
Okay.
you have, what is the timing. So you can do very next day if you want, or you can call her after 3 days also. Okay. So that is
Sure.
not an issue at all.
Okay.
And again, it depends upon patient's convenience, whether she is next. Suppose
Mm.
she has come from far and she would like to
Mm.
get it done very next day. You can admit her and get it done next day in the hospital. So it all depends. Whereas if she's close by,
Okay.
you can send her home and call her after 3 days. Now let us
Oh,
with this as an excuse, let us discuss for the
yes.
benefit of PGs. Should we do
Mm.
universal screening? What do you
So
mean by universal
definitely,
screening
yes.
in the first place?
Yes, sir.
Do for
We
everybody.
do universal.
Yeah,
Yes, sir.
isn't it?
Do it for everybody.
Why?
So, and
Why?
so as we initially spoke about, like we are the diabetic capital and the
Capital is all
incidence is
right.
high.
If we are diabetes
And
capital, then there is probably no need to
no,
do screening. You can consider everybody as diabetic.
yeah,
Can you
yeah.
give me
And
scientific
the
reason?
incidence,
Scientific reason. That's a political statement.
okay. So by scientific reason, like based on the risk stratification, India is
Yes.
also in the Southeast Asian countries are we all fall under the moderate risk category,
Very
where
good.
the literature strongly suggests we need to do a universal screening at the first visit, and
Very
only
good.
if it
Very
is
good. Let's
negative,
stop,
we
stop, stop.
go ahead.
So very good. So in
Yeah.
community medicine, we have learned, suppose the prevalence is very low, okay, then there is no need to
Mm.
screen at all, right? If the
Yes.
prevalence is very high, there is no need to screen, straight away do diagnostic test. Okay.
Yes.
But if it is an
Oh,
intermediate risk, this is the area where a universal screening is required to stratify, isn't it? So you have beautifully
yes.
answered this question, because this question is definitely asked. Why universal screening? Because India is a moderate risk country, and that is why we have to do universal screening. Okay. Now
Okay.
you talked
Mm.
about risk categorization. There is another way of looking at it, is saying that you can, suppose you don't want to do universal screening, you may choose your patients to do the screening or at least the diagnostic test. So what are the different risks in GDM?
So we have low risk and moderate and high risk. Low risk is when the patient's age is less than 25 years and her
Yes,
pre-pregnancy weight is normal. She does not have any family history and does
yes,
not have any history of GDM or DM previously and no bad obstetric history.
yes,
Moderate risk is when her age is more than 25 years and her pre-pregnancy she was overweight and her diabetes is the first degree relatives and she belongs ethnic group like South Asian and East Asian African women.
yes.
High risk is when maternal age is more than 35 with a significant family history of diabetes with personally she has a history of GDM or DM herself and has a repeated glycosuria. All this falls under high risk.
Yeah, so this patient probably is moderate risk because she's 29-year-old. Maybe she was a
Yes.
GDM in the previous pregnancy, which probably nobody knows.
So,
But we can indirectly deduce because of the baby's weight of 3.7 kg at
yes.
8 weeks. And
Mm.
probably she has diabetes in the first degree relatives. I don't know. We'll go to that history later. She is Southeast
Yeah.
Asia or East, I mean, South Asia was, India belongs to that place. So definitely she needs. Now, what are the
Yes.
different screening tests done during to detect GDM? And what is better way of screening in an ideal setup like Manipal, let's say, or any other tertiary care center where even patients are willing to readily do whatever you say. So we'll discuss both, because sometimes examiners they expect you to answer only DIPSI, that is the
Mm.
Indian way. But some examiners, let's say like me, who have been always practicing in Manipal, right? So if I
Yeah.
come as an examiner, I will ask you, what is the ideal? Okay.
Yes.
So a postgraduate should know both. You should not say, this is what is done in my hospital, sir. That's all I know. That shows like
Mm.
arrogance. Okay, both
Yes. Sir.
ways. So
Yes. Sir.
please explain all the tests
Mm.
first, ideal test, and
Okay.
then let us discuss DIPSI also. Okay. Okay.
Yes, sir.
Yeah.
So the best way, the idea in an ideal setup is to screen the patient in the first visit. We screen with random blood sugars. If it is less, it has to be less than 200. Or fasting blood sugars have to be less than 92. And our glycosylated hemoglobin,
Yeah,
HbA1c has to be less than 5 point.
this is called phase one. That means
Yes.
even in first trimester, you want to screen. Ideally, see, when I got this as a theory question during my PG days. I started with pre-pregnancy. You know, a good student always starts with,
Okay.
yeah, pre-pregnancy control of sugar is very important. You know, ideally,
Okay.
what should be the pre-pregnancy HbA1c?
Less than 5.9,
Yes, correct,
5.6
correct.
ideally.
So
Yes.
you can straight away go for a HbA1c pre-pregnancy, especially if the lady belongs to 30 plus age category. So, and only if she is less than 5.9 will you advise pregnancy for her. Okay. So actually your
Okay.
treatment or screening should start pre-pregnancy. That's a good postgraduate. Okay.
Okay.
Then you talk about she became pregnant. And this is ideal setup.
Okay.
I'm not talking about rural setup. I'm not talking about where ladies have to walk 5 kilometers to go to a hospital. They never go in the first trimester at all. I'm not talking about that. Okay. So
Yes.
here, as you said, phase one is you do any one of the three.
Mm.
All three need not be done. Okay. Then
Okay.
comes the
Okay.
phase two. That is second trimester. So here you
Yes, sir.
have
So
either
the
one step.
I yes, sir. In an ideal setup, we go ahead with the one-step method, which is the IAD-PSC method, where
Yes.
we do a glucose tolerance test.
Yeah.
So
So
GTT is
two-step was
done.
when I was a PG and maybe good part of my assistant professorship, we used to do two steps where we used to do a GCT of 50 grams oral glucose after 1 hour
Okay.
and then followed by GTT. But that we have given up from, I think,
Yes.
2016. We went for a one-step test only. So what is this phase
Yes.
two one step practiced in Manipal? As you said, IAD, PSC.
So
Yeah. GTT.
yes, sir. So for GTT, we advise the patient to have this is usually done between 24 to 28 weeks, and where overnight fasting of minimum 8 hours is required. Patient is asked to give a fasting blood sample, venous blood sample, and then followed by 75 grams of anhydrous glucose is mixed with water, and she's made to drink within 5 minutes. And then we repeat her blood sugars after 1 hour and 2 hours. And the cutoff will be fasting should be less than 92. First 1 hour should be less than 180, and 2 hour sugars have to be less than 153. Any one value of abnormal, she will be diagnosed to have gestational diabetes mellitus. And if it is negative, ideally she should be again tested in 28 to 32 weeks, around 30 weeks.
And
So
two-step,
there's a
as I said,
two-step
this is
method.
American way, 50 grams of oral GCT.
Yes,
Let us
sir.
just run through this because we are not going to do this
Okay.
anymore. We'll go to the
Yes, sir.
combined one. That is the Sheshayas or DIPSI. Okay. That is
Dipsy.
diabetes in pregnancy
Yes,
study
sir.
group of India criteria. This is followed by all
Yes,
government
the
hospitals,
national.
all centers in India. Okay. So
Yes,
it's
sir.
almost same
So
20
this
to 28 weeks. Yeah.
Yes, sir. Here also it's irrespective of her fasting status. We when she
This is very
visits
important.
hospital.
Irrespective of the day. That is the
Yes,
most convenient, isn't it?
yes, sir. So anytime we give her 75 grams of anhydrous glucose and again check her glucose values 2 hours later. If it is less than 140, she's told to be normal. More than 140, she's said to have gestational diabetes mellitus. More than 200, we treat her as over DM.
Correct. Very good. So if it is negative, again, you are supposed to repeat at 30 to
Repeat at
34 weeks.
30 weeks.
As you correctly said earlier, we have
Yes,
to
sir.
do a sugar profile. That's why she was referred to Manipal. This is the government of
Yes,
India,
sir.
which is very, very obvious and
Mm.
clear to all of us. Okay. Now,
Yes, sir.
what are the indications to do GTT straight away in first trimester? I am not talking about second trimester, first trimester.
Yes, sir. So the high risk categories are like an elderly female, more than 35 years. And as we said, a strong family history of diabetes, or a patient had diabetes in the previous pregnancy, or a previous history of macrosomia, previous history of a stillbirth, sudden IUD, and a previous history of bad obstetric history if she had, or if she herself is in pre-pregnancy weight, if she falls under obese category. And also if she has young patient with PCOS, or a patient with recurrent abortions with no other causes, with unexplained IUDs, or if this pregnancy she has twin gestations and repeated candida infections, and also if the first time as we said the random and the FBS, if it is more than 200 and FBS more than 92, we prefer to do a GTT in the first trimester.
Yes, so controlling the sugar in first trimester is extremely important because you said that is the one which will give rise to congenital anomalies, especially the cardiac anomalies. There can be fatal anomalies and all that. By the way,
Yes,
do you know what is the signature anomaly of diabetes?
so caudal regression syndrome,
Very good, very good. I'm
sacral
very happy.
agenesis.
Very happy. This is an offhand question which you could answer nicely. These are the questions which will earn you brownie points, Yogi, in the exams.
Okay. Thank you,
Okay.
sir.
So
Yeah.
we have to do GTT even in the first trimester, and the GTT nowadays preferred is the IID PhD GTT only. Gone are the days when we used to do O'Sullivan GTT of 100 grams glucose and all.
Hmm.
First of all, many
Yes.
ladies cannot tolerate, especially in the first trimester, glucose at all. You may have to give antiemetic, or sometimes you may have to give a limbu with that and all that. So we have to give antiemetics half an
Yes.
hour before while doing the GTT. Now, you said sugar
Okay.
profile. What are the things done in sugar profile?
So in sugar profile, we ideally admit the patient and we check her venous blood sample, the fasting sample, and then 2 hours or 1 hour based on the physician's call, post breakfast, lunch, and dinner, sir. So the cutoffs will be fasting should be ideally between 95 to 100, and post breakfast and post prandial sugars in 1 hour should be within 120 to 140. 2 hour sugars should be expected to be 110 to 120. Then we call her well controlled.
Yeah. So instead of complicating so much, like in Manipal, we do simply one is fasting, other one is always
Yes, sir.
2 hour postprandial, that is post breakfast, lunch,
Yes, sir.
and dinner. Now, very easy
Yes.
way to remember. If you say there are so many numbers, what shall I remember? Very easy to remember.
20.
Fasting should be 95. Okay. And
Yes.
2 hours should be 120. 2 hours has got 120 minutes. So 120. Very
Yes,
easy
sir.
to remember. Okay. That's what you are
Yeah.
laughing because I used to always teach this. You must have overheard.
Yes, sir.
Okay.
Yeah.
So 95, or even if you don't want to remember this odd number, say 100 and 120. Good enough.
Okay.
Okay. So now the
Yes,
rule
sir.
of 15 in GDM, that is Gabby's rule. Some examiners have the
Yes,
habit
sir.
of asking this. Do you know this?
Okay. Yes, sir. The Gabby's rule says that with only 15% of people who have GCT positive will be having GDM. And out of them, only 15% will require insulin. And out of these, only 15 will have macrosomia. And only 15% of GDM will progress to type 2 DM as we ideally discussed in the beginning of the session.
So it is 15 for a change. Otherwise, Dr. Pratap used to say always 10%, 10%.
10.
Yeah.
Yes,
Now
sir.
it is 15% here, Gabby. Right. Now,
Yes,
there
sir.
are newer technologies. See, we are talking about Dipsy and all that. But when ideal setup
Yes.
is there, what are the newer technologies of estimating sugars?
So what we call it the reflectance meter is the glucometer that we use in the wards where we just use the capillary blood samples.
Correct.
So they work under the
Now, most
principle
of the
like the blood
ladies, they
contains,
buy it and they do it at home, isn't it? There may
yes,
be a
sir, where
slight
they say
difference
like,
of 5 to 10.
yes, so they call this GRBS as like an SMBG, now self-monitoring blood glucose, because
Yes.
it's easy for the patient to monitor.
Yeah.
So it works on where the glucose from the blood is being acted upon by the glucose oxidase enzyme that are present in the strips.
Okay.
And based on the current or the color they emit, we get the value and we can
Very good.
interpret it.
So what is this continuous glucose monitoring?
So these are coming up in the way now where there's a transdermal patches that are stuck to the body and other methods are there where they continuously check the glucose levels. And what they have found out is there are undetected hyperglycemia and unnoticed hypoglycemia in patients, like nearly 60% in insulin treated patient, but 0% in diet. But I don't know how far we can use it. I have
Yeah,
not seen
these have
anybody
got their
using it.
own flaws here,
Yeah.
as you can see. And,
Yes.
this will have go undetected sometimes. But,
Hmm.
this kind of erratic figures, you don't know how to treat them. And there
Yeah.
is, areas where Manipal, you are sweating a lot, this transdermal accurate assessment may not be possible. Okay, so it is still in the
Yes.
experimental stage. I appreciate
Hmm.
that you don't know how far we can use fine-tuning of insulin regimens based on 3-day assessments with GDM. That is not advisable at all. Okay, so we can